This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
Good evening. My name is Joe Sam Robinson. It's our pleasure to have with us tonight Dr. Paul Dale. Welcome, Paul.
Thanks.
Now, what exactly is a surgical oncologist, which is what you do? What exactly is that?
It is what I do. A surgical oncologist is a general surgeon. So you go through medical school, you go through general surgery residency, and then continue on through a fellowship. And the fellowship is 2 or 3 years, depending on how much research you do during that time period. And during that fellowship period, you're basically learning how to take care of specific types of cancers. Do cancer operations, understand the cancer patient and treatments and options, and then after about 3 years, you're a specialist and trained in just doing surgical oncology.
And so you're sort of a warrior against cancer, which is kind of where our conversation is going to go tonight. Now, we have a rather substantial cancer center here in Macon. Maybe you could chat about that.
Sure, we are certainly making it substantial.
Yes.
The openings was November of last year, and it is the Peyton Anderson Cancer Center at Navison Health, and we're very pleased to be in our brand new building now, and that is going to be Macon's first tertiary type referral cancer center. And basically what that means is you've got sort of a one-stop shop. You can walk through one door, and on the first floor there is the radiation oncologist, the doctors who treat cancer with radiation therapy. The second floor is my office and the GYN oncologists. So you've got surgical oncology, GYN oncology, with more specialties to come in the future. And then the third floor is our breast center. It's a comprehensive one-stop breast center where you can get screening mammography, ultrasound, MRI, biopsies, see the surgeon, everything all on one floor, all in one place. And then the fourth floor is medical oncology and our chemo infusion unit. Very up-to-date, very modern chemo infusion unit where these patients who are coming in or are sick and getting chemotherapy have a very nice place to receive their chemotherapy. And so it's we're also having specialized services offered, such as we have an art therapy room. We have a cooking teaching kitchen where we can give cooking classes. We have a relaxation room. We are going to offer eventually things such as alternative medicines like acupuncture therapy or de-stressing type therapy. So there's a lot of neat options coming through. Yes.
Well, obviously this is it's a big subject. People are quite terrified with cancer. I mean, if I can recollect this, about 25% of deaths have some connection with that, with neoplasms.
Yes, sir.
Absolutely. Certainly, it's a ubiquitous kind of problem. And isn't it getting more, we get it as the population ages, so it's more of an inclination to have cancer as you get older, and the percentages go up?
Yes, sir, absolutely. So second leading cause of death, especially in the more elderly, heart disease continues to be number one, but as we cure that more and more with our new therapies and drugs, etc., I do think that, and people live longer, and the longer we live, the more likelihood our risk of cancer is going to be higher. And so therefore, yes, it probably will continue to grow, and the incidence is continuing to grow.
Well, let's consider the patient. You meant the sort of things you discussed were kind of holistic, the idea of it's just not an organ that you're treating, but you have all these other parts to it.
Right.
I think it is an important issue. When someone has cancer, the stress they're under, and the family stress is a huge thing. So how do you ameliorate that? I mean, you mentioned a stress reduction room. But I mean, the whole coming to grips with the problem is a big deal. It
Big
requires
deal.
spiritual counseling.
Big deal.
You know, lots of life changes happen when someone's afflicted with cancer. Is that right?
Absolutely. Yes, sir. Absolutely. So imagine a lady gets up one morning, she's in the shower. She feels a lump in her breast,
Yes.
and immediately bad thoughts enter her
Right,
brain.
yes, right.
I've got a cancer.
Yes.
Picks up the phone, tells her primary care, I've got a cancer.
Yes.
Well, we need to get a mammogram. Oh, that'll be in 2 weeks.
Yes.
And then you've got a lump there. Well,
Yes.
now we need ultrasound. That'll be
Right.
another few days.
Right.
And it goes through the process,
Yes.
and all the while, this poor person,
Yes.
and it could be a man with prostate, it could be anybody,
Yes.
but your mind is reeling, and you feel like things are just out of
Yes.
control.
Yes.
This cancer has
Yes.
totally consumed
Right.
your
Yeah.
life,
Yes.
and
Yes.
continues to do so. And I think that's why it's important to have the opportunity for a patient to walk in one building and be
Yes.
able to have a discussion with all of the specialists and give them a plan. And I
Yes.
think when the patients get this plan of action,
Yes.
when things are explained, and we
Right,
know that,
right.
that knowledge is power, no doubt about it. So the more a patient can learn, then they can make decisions that empower them again. And all of a sudden, they're making decisions about, should I get my chemotherapy now, or should I wait till after surgery? When do we get radiation? And you discuss it, and they make decisions that impact their care. And that returns some of that out of control feeling back to them. And keep in mind that, say for instance, breast cancer, I mean, one of the things I like to stress to my patients with breast cancer is 85% of all ladies today diagnosed with breast cancer are going to live a good long life and not die of breast cancer. And that's quite remarkable.
Yes. So we could get into some of that. So, firstly, we sort of touched on this a little bit, but in dealing with cancer, discovering the presence of cancer is a big deal. There are different kinds of tests, and the idea is if you pick the neoplasm up at an earlier point, then it's going to be much easier to deal with it. And I know that you spend a lot of time dealing with breast cancer. What should a young lady or middle-aged lady, I mean, what sort of, discovery techniques should be underway for this?
Screening. What screening options do we have for breast cancer is how we'll approach this. So it depends a little bit on if you have a mother with breast cancer, because if you do and your mother was young,
Yes.
you certainly want to start screening before she got hers. And we recommend about 5 to 10 years prior to the age of, if your mother was in her 30s, you may want to start going and seeing somebody in your 20s
Yes.
and having good examinations and possibly other exams. But say, for instance, you had no family history whatsoever of breast cancer.
Yes.
And a lot of women think, well, I have no family history of breast cancer, I'm not going to get breast cancer. The problem is that a majority of women who get breast cancer have no risk factors whatsoever. 65-70% are just women who get breast cancer because 1 in 7 women get breast cancer.
Well, discussing that, I mean, we have these, I often hear the question at least with my neurosurgery patients, what caused it, how did this happen?
Yeah,
And so
yeah, that's a
understanding
great
the cause
question.
is quite complicated. You mentioned sort of parenthetically heredity. What are some more risk factors? What about nursing or not nursing, or what are some risk factors out there for developing cancer, breast cancer?
We've already talked about one of those, age.
Yes.
The older you get, the higher the risk goes,
Right.
no matter what,
Right,
no
yes,
matter what.
right,
So
yeah.
if you don't die of a heart attack when you're 50,
Yes,
then your
right,
risk of
right,
getting
right,
a
right,
cancer
right,
goes
yes,
up.
yes.
So age, family history,
Yes, right.
having a mother
Right.
that's premenopausal
Yes.
increases your risk 3 times versus postmenopausal, which is only 1.5
Right,
times.
yes, yes.
So it matters how old your family
Yes, right.
Also, having ovarian cancer in your mother, then you're looking at the possibility of having some kind of a genetic
Yes,
type
yes,
cancer.
right.
And we can talk later about the BRCA1 and BRCA2 type
Yes,
cancers,
yes.
which are a totally separate risk factor because they increase your risk extremely so.
Yes.
So, family history, early age of menarche, or late menopause.
Yes.
So it's that estrogen cycle exposure, the exposure to the cyclic estrogen, unopposed, especially if you're nulliparous, then
Yes.
you've never had children. It slightly increases your risk because having the children breaks that cycle
Yes.
and seems to reduce the risk a little bit.
Yes.
If you have children, breastfeeding, there's the Leche League and others have a strong feeling that breastfeeding significantly reduces risk. It may reduce risk. Significantly, I wouldn't say, but it may a little bit.
Yes.
Other things such as obesity might slightly increase the risk. And there's others that are related to exercise. We think that perhaps exercise reduces, but that may be body habits and things like that. So these are some of the risk factors that, unfortunately, or most women don't have. They have very few of these and wind up getting breast cancer, which is rather interesting.
Well, I mean, what about birth controls and what about hormonal supplements in post?
That's a great question because in the 50s, 60s, we thought we'd found the holy grail for women. They're going to feel fantastic. They can all go on estrogen supplementation.
Yes, right.
And indeed, it does. It makes them feel that much better. There's no doubt about it. Actually, estrogen alone doesn't significantly, it doesn't increase your risk as if you start to get into estrogen and progesterone stimulation.
Yes.
And that does increase the risk. Birth control pills doesn't really significantly increase the risk. So some of these things, especially the ones that just have the estrogen, does increase the risk slightly, but the cardioprotective and other things like that maybe over, outweigh that a little bit. So when women come to me and they've had breast cancer,
Right.
and they say, well, Dr. Dale, do I have to come off my hormones? My answer usually is, and the standard answer should be, yes, you should.
Yes.
Especially if your tumor was estrogen receptor positive.
Right, yes.
Because that's a special type of tumor. That means that tumor is growing because your estrogen is feeding it.
Yes.
So what we do in those ladies is block the estrogen. So if your tumor is estrogen positive, you certainly don't want to take exogenous or extra estrogen.
Yes.
But a lot of times women say, well, I'm going to kill somebody if I don't take my hormones, and I've heard it, and I say, I understand, and then you have to come to an agreement of, well, you may be slightly increasing your risk for breast cancer coming back, but it'd be better than going to jail for killing somebody. So which way do you go on that? So each person has to have that conversation, I think, with their individual physician.
So, I mean, I won't overkill the different therapeutic modalities that are out there, but we might discuss a little bit. So, I know there's a lot of complexities involved. What kind of issues you're dealing with? But traditionally, people would do radical mastectomies, and that's not as much in vogue these days, or sometimes people do it. Any comments about different surgical approaches?
So to answer the first question, screening at age 40 is what I would recommend.
Yes.
Every woman start at age 40. Get your annual mammograms. There's some data now suggesting, you only need it every 2 years. And some people say, don't wait till your 50s. I personally think that, and the American College of Surgeons and the American Radiology Society all recommend screening annually at age 40. So I highly recommend that. There's a new machine out now if you've got very dense breast tissue. The neat thing is that you can have what we call tomography.
Yes.
And tomography is like 3D X-ray of the breast.
Yes.
And so for women who have very dense breasts, having a tomogram might be the way to go. And I do think, and I've seen this technology used at my former institution at the University of Missouri, and it's outstanding what you can see compared to plain digital digital X-ray. So finding it very small is very, very important, ultimately important.
Yes.
So let's talk a little bit about the treatment.
Yes.
Let's go back 100 years. 100 years, turn of the century.
Yes.
If you had breast cancer, you would have a lump. They didn't have X-rays. They didn't have radiology. So basically, it was, I've got a lump in my breast.
Right.
And there's some fantastic books that you can read on the history of medicine and what they used to do. And some of the stories are quite gruesome of coming down. A lady, one of the president's cousins had breast cancer at the turn of the century, a little bit before, in the late 1800s. And the surgeon came from Boston and came to her house. And they had a roaring fire. The dog was sitting there. And she came downstairs, actually, and this is all in this account. And she basically sat in a chair, and he did the surgery with her sitting in her parlor.
Oh, really? Wow.
With a knife and a poker in the oven, a cautery iron in the iron.
It's really barbaric.
Oh my gosh! And then she gets up and she says, I'm so sorry for crying out, and goes back upstairs.
Wow.
Now that poor woman has a 50-50 chance of dying of infection, not of breast cancer.
That's correct. So a lot of barbaric.
So we've come a long way, thank goodness.
It's a lot of discussion about the appropriate kind of operative intervention.
Absolutely.
I think that many people sort of try and be minimalistic, and contrary-wise, some people do bilateral mastectomies.
Yeah.
Any comments on bilateral mastectomies?
Yeah, I do have some comments. So we've come a long way, 100 years, then basically anesthesia was developed, thank goodness.
Yes.
Now we can have safe operations.
Right,
And women
yes.
don't have to go through that horribleness. Now,
Yes.
then all of a sudden, Halsted, the father of American surgery,
Yes.
and he actually popularized the Halsted radical mastectomy.
Yes.
And that's where you take off the breast,
Yes.
you take off the chest wall muscles,
Yes.
and you take all the lymph nodes from underneath the armpit.
Yes.
Radical surgery. And he was so radical that he wouldn't even close the hole. He would leave it open. And one of his famous quotes is that age is, he said basically that the morbidity associated with the surgery was of very little importance as long as they cured the cancer, because these patients were old. They were nearly 50 years old and they were no longer
Right,
useful
right,
in our
right,
society.
right.
So, because nobody lived that long.
That's
Very
right.
interesting
Yes,
quote back
yes,
then.
Yes.
So he popularized the radical, and then a doctor in England could popularize the modified radical, the less invasive
Yes.
procedure, where you save the muscle.
Yes.
And then for a short while, we went back the opposite way and did an urban procedure. Urban procedures where they took out all the lymph nodes along the chest wall.
Yes.
Lost blood, and I don't. Did
Right.
you see? You may have seen these when you were in training.
A
the
younger
urban
boy.
procedure.
Yeah. The name's familiar. The name's
Yeah,
familiar.
yeah.
Yes.
Well, actually, after just 10 years of doing that, Dr. Urban says, you know what? It really doesn't help any.
Yes.
So we went less radical. We went from the radical to the modified, and then all of a sudden, what if we just take out Bernard Fisher and Umberto Veronese in Italy came up with the concept, what if we just take out the lump?
Yes.
And don't do a
Right,
radical procedure and save the breast.
Yes.
And they did a study where they did a lumpectomy, and they did a lumpectomy followed by radiation.
Yes.
And what they found was that they had to stop the study because the recurrence rate was too high in one of the arms.
Yes.
And it was the non-radiated breast.
Yes, yes.
40-50% recurrence rates
Right.
versus 10-15% recurrence
Yes.
rates. So that all of a sudden became the standard of care. And every time we've made a progression, we've compared it to the old gold
Yeah,
standard.
yes.
So we're not giving up anything, yet we're getting less and less invasive. So some very nice things have happened in the last 20 years.
Yes.
One of those is you no longer have to be radical with the lymph nodes.
Yes.
You can take out one lymph node instead of taking all the lymph nodes. Because what we know is that taking the lymph nodes out doesn't significantly increase your...
Is this the
Chance of
so-called
living.
sentinel lymph node?
That
Maybe
is
you want to talk
exactly
about
what
that.
it is. Exactly.
Why don't you talk about
The
this?
sentinel node technology, actually, the sentinel node biopsy is where you take you have a cancer, and you inject a dye around the cancer, and then the dye goes along and it goes to the first draining lymph node. And if you take that one lymph node
Yes.
out, and it's negative, then we know it hasn't spread.
Yes.
It was originally popularized by one of my heroes and one of my mentors, Dr. Donald Morton,
Yes.
at the John Wayne Cancer Institute, where I trained.
Yes.
He developed this in the 1980s for melanoma.
Yes.
And then Dr. Armando Giuliano, who also, where I trained, developed it for breast cancer.
Yes.
And it is now the mainstay of treatment for patients with breast cancer.
Yes.
Instead of taking all your lymph nodes, you get to have a sentinel node biopsy, where you take out one lymph node.
So we can preserve the arm, the circulation of the arm.
Absolutely.
Those edematous arms are far less common.
Far less common, less than 1%.
Yes,
Less
well,
than 1%.
that's a good story, isn't it? Well, we have all these complexities about treatment of breast cancer. One of the issues that happens, and indeed with any kind of cancer, is we get metastases later, and I think it's a long period that needs to be watched. Any comment about how the possibilities over a decade of reoccurrence and how you manage that, and it turns out if you get these stage 4 problems, it can really be a
Can be horrible.
Yes,
Absolutely
yes,
horrible. That's
yes.
why, unfortunately, 15% of patients with cancer die
Yes.
of breast cancer because they develop metastases. Their cancer spreads from the breast to the lymph nodes or through the bloodstream to other areas of the body. It can go to the brain, the lungs, the bones,
Yes, yes.
the liver, and then it's a real bugaboo. That's the problem when that happens. And then we have to rely on things like chemotherapy, because my surgical blade isn't going to
Yes.
cut it out. All you got to do is leave one cell,
Yes.
and boom, it keeps
Right,
coming
right,
back.
yes.
Radiation oncology, where they x-ray the area, can help in certain cases, and it does provide relief of pain,
Yes.
or even sometimes a cure of certain areas of metastatic disease. So radiation oncology and surgery go hand in hand. And then medical oncology is basically is when they give the chemotherapy to go throughout the whole body. And it's hard, or most of my patients don't understand how it all works. They think that the radiation goes to the whole body. Well, it doesn't. Radiation, just like in brain cancer, it's all focused in one area, versus chemotherapy, which does go throughout the body and try to reduce the incidence of metastatic disease. Because once it does spread, then the cat's out of the bag. We've got a harder time getting it under control. Now, at one time, I would have sat here and said, that's it, you got 6 months, goodbye, that's all. But now we have better drugs. The drugs, the chemotherapeutic and immunomodulators, these new drugs that are actually upregulating our own immune systems to help fight cancer and to go out and find these cancers and actually kill them. Things like this are coming along, and targeted therapies that have the ability to go and fight a cancer based on its molecular makeup and what receptors it might have on its surface. And a great example of that is the HER2 receptor on the surface of a cancer, and Herceptin. So if your cancer is a HER2 positive cancer, then you're going to receive a special drug that can target that receptor called Herceptin. And the Herceptin will bind to the receptor and kill the cancer cell, and it doesn't kill non-HER2 positive cells.
So we can maybe just get into a little bit about some of the progress that's occurred. And I think many times people criticize the American healthcare system. They say, if I could only live in France or wherever they like to live, where everything is great. Really, if you look at the cutting edge technology that's been developed in the United States and the treatment for all kinds of complicated problems, particularly neoplasms and how to handle cancer, we've done a very good job. Now, some of the issues out there are genomic testing, which you sort of alluded to a little bit. Can you talk about that? I mean, do you routinely get genomic testing, or when would you do that, and what is genomic testing?
So genetic testing basically is looking at the patient's chromosomal makeup and whether or not they have certain genes that predispose them to having a cancer.
Yes.
And that is now being done. It's quite remarkable. Some of the earliest genes we knew about regarding breast cancer are the BRCA1 and BRCA2 genes, the breast cancer 1, breast cancer 2. And this came to light recently because of the Angelina Jolie situation.
What is that situation? I haven't been keeping up with that. What happened with Angelina?
Angelina's very well known. She's a gorgeous movie star.
Gee, that shows you how naive I am.
Good job,
She's a public figure, I guess.
She is.
I'll have to take lessons on that. Okay.
Public figure, very well known, and she announced one day that I have this gene and I'm going to have a prophylactic mastectomy.
Yes.
So basically, when you have this gene, your risk of cancer increases to 65 to 85% over your lifetime.
Yes.
Well, that's awful high.
That's a big number.
That's a huge number. So if I came up to you and said, Joe Sam, guess what? You're going to get breast cancer, 85% chance. What do you want to do? And there are things she could have done. She went for one treatment option. There are treatment options. So I have a fair number of patients that come to see me who have this disorder. And basically a lot of them were younger women who still want to have a family. They want to breastfeed. And they're 25. And what do I do, Dr. Dale? I says, well, you know what we're going to do? Because most of the cancers occur a little later than 25. They're usually 35, 45, 55.
Yes.
So we say, well, we don't have to do it right now. We're going to follow you closely. We'll do MRIs.
Yes.
We can do biannual examinations. We can do mammography and keep a close eye. And if something should show up, we hope to find it. That's one option. Second option is we can put you on an anti-estrogen pill called tamoxifen.
Yes. And
that'll reduce your risk. We're not quite sure in this group how much it reduces the risk, because if you have an ER positive tumor and I put you on tamoxifen, it reduces your chance of it coming back by 50%.
Yes.
We're not sure if it reduces a woman with a BRCA 150%, but it certainly reduces her risk.
Yes.
So that's another option. Close observation with the tamoxifen. And then the last option would be to remove the breast and have a prophylactic mastectomy. Now, Angelina did a prophylactic mastectomy, but she also had reconstruction.
Yes.
It surprised me somewhat. I think that she did not have immediate reconstruction. It was one of the things we offer right here in Macon, where if I have a lady and she chooses not to save her breast, or she
Yes.
can't because of tuber size or some other problem, she could have a mastectomy, and when I'm done, during the same time she's asleep, in would come one of our plastic surgeons
Yes.
who can offer her reconstruction. And the neat thing is, there's some really cool advances in the reconstruction field that allows a woman to have either expander put in underneath
Yes.
their muscle and it blows it up, and then they take that out and put an artificial
Right,
breast,
yes.
or actually maneuvering their own tissue.
Yes.
And some ladies have what we call a tram flap, or even a dip flap, where they actually they take the fatty tissue and the skin from the belly,
Yes.
and they base it on their arterial supply, and they take it up and they put it in here and hook it into the internal mammary artery, and it makes them a new breast that way. And then they get a tummy tuck out of it. So
Pretty
it's
cool,
kind of
pretty
a
cool.
2-for-1er. Yeah.
How about pregnancies? I mean, isn't that's going to be a role? I mean, you discourage a person at risk. A pregnancy would be something that would interface.
It
with
does.
decision.
And having women, so you're regarding, so if you're BRCA
Right,
positive,
and you want to have children.
50% chance, because this is on a chromosome that's non-sexually. So it therefore is 50% chance. And you've got,
Yes.
and so there are women out there that have babies, they want to have babies, and when do we start talking to their children? So
Yes, yes.
so there's we're finding out a lot. There's other genes that we're finding out that are associated with breast cancer, colon cancer, pancreatic cancer. And
Yes,
so that's
yes.
the benefit of genomic testing, genetic testing, to find out what is your risk. Should everybody do it? Absolutely
Yes,
not. Should
yes.
people with a strong family history do it? Absolutely. One of the benefits of our cancer center is we have a wonderful genetic counselor who has the capability of discussing your family history, writing it all down, and determining what your risk is and whether or not you should be tested. So we're very fortunate, and she's worth her weight in gold, Darcy
Yes,
is.
yes,
And
yes.
not many institutions have their own genetic counselor. So we're very fortunate to have that here, right here in Macon.
Yes. So many people that go through the ordeal of breast cancer, they're going to have a pretty normal life, but there's always the stress and danger and anxiety. Will it reoccur? And
Always.
so how do you deal with that? You suggest what would you suggest to a patient that's had successful surgery, and how are you going to follow those patients?
So one of the most frightful times, right now there's a big push of looking survivorship.
Yes.
There's a big national push on survivorship. In fact, that's
Yes.
one of our requirements. We have to have a survivorship plan in place
Yes.
to follow these patients, because one of the scariest days is going to come when I say, you're 5 years out, you're doing great, the chance to come back to it, and I don't need to see you anymore. Oh no, yes you do,
Right,
Dr.
right,
Dale.
yes,
You've
right,
got to
sure,
see me forever and ever and
sure,
ever.
sure.
But I can't see everybody forever and ever because I couldn't see another new patient.
Right,
So,
yes.
so you're right, and it's always a concern. But unlike some breast cancers, when you're 5 and 10 years out, you've got an excellent chance
Yes.
at being cured of
Right,
that cancer.
right.
In fact, your risk of getting
Right,
another cancer
right.
may be higher than that
Right,
one coming
right,
back.
Right.
Versus other, so for instance, melanoma, which we didn't talk. We'll come back and talk about melanoma sometime.
Yes. Right.
But for breast cancer, I think that the reassurance
Yes.
and handing them off to a good, capable primary care doctor who knows to follow them and
Yes,
keep an eye
yes.
and make sure that, then that's all you can do at this point.
There are a lot of cancers
Reassurance.
we could talk about.
We
It seems to
could.
me the ladies, if I can say it this way, are it's a very difficult thing to go through, and the sisterhood seems to kick in gear, and there's a lot.
Oh,
they
they're
try,
amazing.
They try and put a supportive mechanism
Yes,
in place. Contrary-wise, the males who have prostate cancer,
We're terrible.
they just go in the corner, and
We're terrible.
there's not much of a prostate support
There's
mechanism,
not.
and which is it's a problem. I think there's nothing to be ashamed about having cancer, and as much support as you can get, so much the better. Well, all right, you've got maybe 1 minute left here. So how do you see progress in breast cancer in the future? What do you think is going to come? Better testing, better treatment? What do you see in 5 or 10 years are really going to be there?
I think we're going to get less invasive in our surgeries. I think we're going to get much better therapeutic agents that are targeted agents.
Yes.
I think that eventually we may be able to actually look at your genomic makeup and say, you know what, you're probably going to get a breast cancer when you're 50 or
Yes,
60.
right,
I mean,
yes.
that we may get that much knowledge out of the entire genome and
Yes,
knowing
yes.
what we're dealing with there. So I think that will screening come into play? Absolutely. I mean, we're still going to have screening and such, but having these new therapeutic treatment modalities, and perhaps Paul Dale as a surgical oncologist will have less and less of a role to play,
Yes.
and there'll be more of prevention, early detection,
Yes.
and treatment by other modalities.
Well, Paul, it's been great having you here. It's
great
been a
being here,
very erudite conversation, and we can hope that the American healthcare system is going to live up to its responsibility to look after everyone with whatever afflictions that unfortunately come their way. So thank you once again.
Thank you, sir. Thanks for having me.
Yes, sir. Thank you.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.